Well, we're right on track. So the next case is Dr. Castaneda, also from New York. He's going to present a case of drug-induced acute eosinophilic pneumonia.
Thank you. Good morning, everyone. My name is Christian Castaneda, and I'm a third-year medical resident from New York Presbyterian Queens. I'm here and honored to share a case with you, Levofloxacin-induced acute eosinophilic pneumonitis. I have no disclosures other than the fact that I am extremely nervous right now. So our patient was a 49-year-old Asian dentist who initially presented to his primary doctor with upper respiratory tract symptoms. He was prescribed 10 days of levofloxacin 500 milligrams once daily. 2 days after completing this antibiotic course, he developed fevers and worsening dyspnea on exertion. It should be noted that he had no history of any pulmonary pathology, including asthma. He had no pets at home. He had been living in the same home for the past 3 years with no mold problems or anything like that. No recent travel and no sick contacts, but you should be aware that he was born in Libya and for a period of his life lived in Taiwan. He presented to us profoundly hypoxemic, requiring 100% non-rebreather. He was in addition afebrile but tachycardic and tachypnic. Physical exam was significant for severe respiratory distress. He was unable to speak full sentences. There was no stridor or cyanosis, but on lung exam he had coarse rales throughout his lung fields, bilaterally. His labs on presentation were significant for a leukocytosis to 15,000 with an eosinophilic predominance of 19%. In addition, he had markedly elevated IgE levels to 2,200. Urine studies for Legionella streptococcus and mycoplasma were negative, as well as HIV and flu. And his arterial blood gas on 100% non-rebreather showed a mild respiratory alkalosis, as well as a markedly elevated AA gradient. This was the patient's AP film on presentation, significant for reticulonodular opacities in the right lung field. And his non-contrast CT of the lung demonstrated ground glass opacities in the anterior and posterior portions of the right upper lung, peripherally based. In addition, there was subtracheal and subcarinal lymphadenopathy. So he was deemed unstable for bronchoscopy initially and transferred to our medical ICU. At this time, the differential diagnoses that we considered were just a severe community-acquired pneumonia because he was a relatively healthy young gentleman, aspergillosis secondary to the eosinophilia, a cryptogenic organizing pneumonia because of the ground glass opacities on CT. We also considered tuberculosis because of his history of living abroad, and he was born in Libya, in addition to the upper lobe predilection of the ground glass opacities. We considered parasitic infections such as strongyloides, and then of course we considered eosinophilic pneumonia. Patient was started on broad-spectrum antibiotics, high-dose corticosteroids. He was covered empirically with ivermectin for the strongyloides. Unfortunately, his respiratory status continued to worsen, and he was intubated and taken for bronchoscopy. Direct visualization of the airways via flexible bronchoscopy revealed thick mucus plugging throughout both the proximal and distal airways. It was easily cleared by saline, however. BAL fluid analysis revealed eosinophils to 45%, and initial cultures of the blood, sputum, and BAL fluids were all unrevealing. Thankfully, his dyspnea improved on the 4th day of IV steroids, and he was eventually extubated and discharged on hospital day 9. Post-discharge, his sputum and BAL AFB cultures and fungal cultures all returned negative at 4 and 6 weeks, and antigen assays for strongyloides and fungal markers returned negative. He has since followed up closely with our pulmonary clinic and has done well, and his IgE levels have interestingly downtrended as an outpatient. So I'm going to talk briefly about acute eosinophilic pneumonia. It was first described by Dr. James Allen, who I believe is presenting later today on the same topic, in 1989. We'll talk about why this is important and then why we think this is a quinolone-induced eosinophilic pneumonia. So why do we care? The presentation and constellation of symptoms that these patients present with can closely mimic a number of different diseases with high morbidity and mortality, including tuberculosis, aspergillosis, and for us, most importantly, ARDS. This patient met 3 out of 4 of the Berlin definition for ARDS. And in a case series of 22 patients with AEP, half needed mechanical ventilation. Of course, our patient needed mechanical ventilation as well. So we need to recognize and treat this very, very quickly. So the pathophysiology is poorly understood, especially because it was first described in only 1989. Some reports indicate a type 1 hypersensitivity and an immediate reaction, but there are also subacute presentations with like a type 3 hypersensitivity. In a review, regardless of the pathophysiology, most of these patients present with very nonspecific symptoms such as fevers, cough, dyspnea, and exertion, in addition to nonspecific infiltrates on radiography. So once again, as this is a relatively new clinical entity, there are not any defined diagnostic criteria. Initially, Dr. Allen suggested that you need tissue biopsy to make the diagnosis, but more recently, most authors agree that you can make the diagnosis off increased eosinophils in the BAL fluid in addition to infiltrates on radiography. The treatment for this includes discontinuing the offending therapy. The problem is that a lot of times we don't know what the offending therapy is. We also start high-dose IV corticosteroids, but interestingly, there are some case reports describing AEP resolving spontaneously without the use of steroids. In addition, if our clinical suspicion is high for aspergillosis, we need to use caution when just starting the patient on steroids, as it could make these patients worse. In this situation, you might need tissue biopsy before starting the steroids. So while classically drugs like nitrofurantoin, amiodarone, methotrexate, and more recently daptomycin have been implicated in drug-induced AEP, there are some case reports describing quinolone-induced hypersensitivities. It's very rare. These case reports describe both, again, an immediate type 1 hypersensitivity and a type 3 delayed hypersensitivity. In our review of the literature, there were only 2 previous case reports describing a quinolone-induced AEP. One was from Japan in 2000, and one was from Italy in 2010. Both of these patients received levofloxacin and developed eosinophilic infiltrates shortly thereafter. We believe that this is the 3rd case of levofloxacin-induced AEP. So take-home points. Despite being very rare, because of the very high morbidity and mortality, we need to diagnose these patients early. Worldwide, quinolone prescriptions are increasing, and as these prescriptions are increasing, we expect incidence of case reports like this to increase. And we definitely need more research into the pathophysiologic basis of this phenomenon. Thank you very much for your time, guys.
Questions for our speaker?
Yeah, just a
Go ahead.
general question. But do you guys have any labs before they started the levofloxacin? Was any eosinophil at that point or not?
We do not have any labs before the levofloxacin, unfortunately.
Nice presentation. I just have a question. The chest X-ray and the CT, the degree of hypoxia doesn't fit, the amount of infiltrates there. And she came in with shortness of breath to begin with. So I'm wondering if you could just comment on that. I don't know if you know the answer.
The chest X-ray and CT were done on hospital day 1, and he wasn't intubated until hospital day 4. We were pretty surprised about the level of hypoxemia as well. But when we did the bronchoscopy, it was just thick mucus plugging everywhere. So there was some discrepancy between direct visualization of the airways and the radiographic findings. Maybe it progressively worsened during the hospital stay. We're not really sure, but it was fairly impressive, yeah.
Sorry, one more question.
Yes, sir, no problem.
I know that you mentioned that the levofloxacin was discontinued 2 days prior to his presentation. So did the other case reports mention anything about, because usually one of the things that we do is obviously discontinue the offending medication. So how did the prior case reports, in terms of, how did they actually just stop the antibiotic and, not do steroids, or did they need to do steroids to actually improve the eosinophilic pneumonia?
So in the 2 case reports for specifically levofloxacin, they stopped the levofloxacin and started IV steroids. It was more of like an immediate hypersensitivity in those 2. So they started the levofloxacin, and like 2 days later, the infiltrates happened. For us, it was a little bit more delayed.
So, and the reason that you guys think that it got worse despite stopping the antibiotics was just a worsening of the eosinophilic pneumonia? Or?
We think so.
The presence of elevated IgE levels, that's a little off. Generally, with eosinophilic pneumonia, you don't necessarily see elevated IgE levels. And I'm wondering if in this patient with the thick mucus plugging, elevated IgE and eosinophilia, if ABPA or something like that should be taken into consideration. Obviously, I did not see any evidence of bronchiectasis per se, but I did not understand the elevated IgE levels in acute eosinophilic pneumonia.
So ABPA was one of our top differentials, especially considering the elevated IgE. Of note, the mucus plugging was like very easily cleared. From what I understand, my minimal understanding of ABPA, when you bronchoscope them, it's very hard to clear the mucus, as well as all fungal cultures came back negative, and Aspergillus antigen came back negative. So definitely high on our differential. Thank you very much, guys.
Very nice presentation.